Thank you. I'm going to talk about I was asked to talk about a very specific topic, and we looked at patients who had disease in the chest and abdomen who underwent surgery. So I'll explain how this came up. I have a lot of disclosures, mainly federal grants or clinical trial supports, but not relevant to this. And so something I want to mention before this is, as you guys are keenly aware, that this is a bad disease, and patients' survivals can be quite limited, as many of y'all suffered with. But if you look back at 2012, the patients who had curative intent surgery in ISLAC, which is an international consortium of centers that puts data together in order to study how patients do, show that about half the patients live 18 months or longer in that group. Recently, all this data has been redone, and so the patients that have been treated since 2012 have been added. And fortunately, what we're seeing in this data that was just published this summer with the same organization but with updated data is that survivals of patients who have undergone surgery is vastly better. As you can see here from stage 1 to 4, the survivals are even approaching 60% at 3 years, which is some of the best data we've seen. This is now online in 5 different publications from the International Association of the Study of Lung Cancer. And similarly, I think this figure shows our data very well. Now, right here, this is a combination of patients who did and did not receive surgery, which is showing, fortunately, patients are doing better than they had in the past. If you look specifically at the patients who had tumor defined at surgery, meaning the stage was done when the tumor was resected, so we have the best data for those patients, the most specimens to analyze, it showed that patients with and without nodal disease still had 3-year survivals of over 40%. And I bring this up today because we are now seeing an improvement in survival of patients with this disease, which is really good news, and hopefully we can get this to continue. So I'm going to talk about something very briefly, and I probably made this a touch too scientific, but when patients have mesothelioma and they come to us and say, should I undergo surgery? A part of what you want to do is, 1, name the disease. It's important to get a biopsy and really be sure what it is, and 2, stage the disease. And as part of that is, if a patient has disease in the chest, as many of y'all know, they are at risk for the disease in the abdomen as well. And so if you look only with imaging, meaning a CT or PET, the ability to predict that disease is low, only 17%. Similarly, if it's absent, there is still a large group of patients who will have disease even though the imaging is negative. And so what we do is we put a laparoscope in the abdomen to look. Given that this disease is based on a surface, using scans to look at that surface is very hard. And so if there's suspicion, directly looking with biopsies is much more accurate than using imaging. And so what we have noted is PET and or CT suggestive peritoneal disease needs biopsies because sometimes it's not positive. Suspicious lesions need pathology because about 50% of lesions in the abdomen could be something else, and often they're nothing. And then diagnostic laparoscopy, meaning put a scope in the abdomen to stage the patient, is important before you do chest surgery. So that led to a question. I adopted this practice years ago of looking at the abdomen to make sure the disease isn't present. So what if it is? What do we do with these patients? And so how do we manage patients with peritoneal disease that's detected during staging when we're considering surgery for the chest? And so I looked at this in a small studies to evaluate the long-term survivals of patients undergoing cytoreductive surgery for bicavitary meso, meaning in the chest and abdomen. And are there any indicators of patients who would do well and want to do well? And so I looked at the literature, and this study is a mix of about 50 patients who were studied in New York who had disease operating on one site and then had disease in others. And it shows the overall survivals of the people who were diagnosed at the same time at different times based on the first intervention and the second, but it doesn't actually study patients who had surgery in both compartments. So from what I could tell, there's really no report on this. So we look back at all our data, and we use the data that we collect based on that staging system that I mentioned called International Association for the Study of Lung Cancer in our own institutional data set at Baylor College of Medicine. And we really looked at our data from 2014 to 2021. And by that time, we had evaluated over 400 patients, and 3% noted to have disease in the belly as well as the chest, who ended up undergoing surgery. Most underwent surgery of the chest first, or 13 out of 14, and about half, or 43%, had the approach where you take the lung out, called an extrapleural pneumonectomy, and the other half had one where you took the lining out, which Dr. Hong just discussed. And so the patients were relatively similar. They had different stages based on preoperative imaging, but when you looked at the final pathology, the extent of the disease was relatively similar. The T3 stage, which is the more advanced one we can resect, was about 70% in both. The patients had disease in about a third in the nodes, and that changed or upstaged about double that when we looked even more closely. Most patients who have belly surgery, as some of you in the room know, require different parts of the belly to be managed. Maybe the spleen, maybe the colon, maybe the small bowel. It really is patient specific. And we noted that patients did pretty well. Over half the patients lived almost 3 years after this operation, as you can see here. But interestingly, we looked at the patients who had the lung removed versus the lung not removed, or the EPD versus the EPP, the extrapleural pneumonectomy. And we noticed that the patients who underwent belly surgery after having their lung removed did not do nearly as well as those who underwent belly surgery after having their lungs spared, and that the survivals that we saw were around nearly 5 years with not removing the lung, as opposed to just over a year when it was removed. So, and similarly, the disease recurred more frequently in the patients who had the previous lung removed rather than spared. So what we noted for this very small group of 3% of patients with disease in 2 cavities, long-term survival can be achieved with a very aggressive surgical approach in 2 cavities. Patients undergoing the lung sparing approach seem to have much better outcome compared to those having the lung removal approach, and so that's an approach that we take. And so once again, I want to thank my whole team and all the collaborators we have, which is very extensive. And then I want to thank all of you for joining us today at this meeting, and happy to answer any questions.
Any questions for Dr. Ripley? One right here in front.
Yeah, hello. I'm curious about the MARS-2 study, because whenever I've been speaking to my oncologist, there's just, and we spoke to surgeons, and there's just a general reluctance to perform this surgery because they just say that the MARS-2 study just showed no benefit of surgery. And then, you know, it's kind of, where do you go? Do you...
Yeah, I wasn't asked to speak on MARS-2, so I didn't bring that up. MARS-2, for those of you who know, compared surgical resection to chemotherapy alone. It was performed in Britain and showed that patients with chemo did a little bit better than the patients with surgery. The study is interesting, and I really applaud the investigators for being able to randomize and study all the patients, but that study had several flaws. One of the problems was the patients didn't do that well at surgery. 9% actually died post-operatively, which is high, too high. And the other issue, to get into the weeds, is the patients were not randomized at the front of treatment. They received chemotherapy, and those who did well then went on to surgery or more chemotherapy, as opposed to enrolling patients when they present and put them in a strategy of chemo followed by surgery. So that trial design really selected for patients who probably did well on chemo, and that's reflected at the survivals on their chemo arm were higher than any other trial ever seen, and they were actually higher than their predicted survivals that they published in their trials protocol, which was published about 4 years before this one, as their expected outcomes. And similarly, the surgical outcomes are pretty low. The patient survival after surgery is really almost identical to the survival after surgery in the 1990s, when the first series came out, before patient selection was better, before PET scans were even used. And what we see in most of our centers, as well as the international data, is that the survivals are substantially higher in the recent decade as compared to the 1990s. And so I don't think we should throw out surgery at this point. And I think that patients who are treated with chemo only in lieu of surgery may miss an opportunity to remove the disease, but surgery is not the only answer. And it's only an answer for a small percentage of patients. And so it's at least worth a discussion in an appointment with people who can offer it. And it may not be the right option for you.
Question down the far end, Dr. Ripley. Locke, do you need a microphone?
Yeah. Just for people online.
Sure.
Dr. Ripley, thank you, first of all, for your presentation and research. Quick question regarding timing of surgery. Is there any evidence in terms of it being more efficacious, like if you do it early in the disease versus later in the disease? Because it feels like you only have so many bullets in terms of surgery. So when do you pull that trigger?
I'll preface this in the just to explain for a second. The question is, should patients get neoadjuvant therapy and surgery, or should they go to surgery and then get adjuvant therapy? So chemotherapy is administered essentially three ways. It's administered before a surgical resection, after a surgical resection, or it's just administered for disease without surgery part of it. And so before surgery means neoadjuvant, after surgery means adjuvant, or adjuvant means after surgery. So should you get chemo and then surgery, or you should get surgery and chemo for patients who are appropriate? What we know is most patients don't respond to chemotherapy. And if patients get chemotherapy and followed by surgery, the chance of progression is about 33 to 36%. I think the best trial for this is really Andreas Remner's imprint study, in which they enrolled patients to get radiotherapy after surgery, but they gave everybody chemo, then surgery, and then radiotherapy. And about a third of the patients progressed and no longer were surgical candidates. Based on that data, a lot of our programs have adopted surgery up front for at least the patients without nodal or advanced disease. Exactly where you draw that line is a bit hard, and it's changed with Mars too. And so I think surgical candidate operating up front is still probably the right answer. But the approach I'm taking right now is currently we have a trial, I've called it NEMO, meaning neoadjuvant mesothelioma, in which we give 3 cycles of dual agent immunotherapy or dual agent immunotherapy with chemo, followed by surgery, followed by a year of immunotherapy. So my bias is the patients we've seen with the best survivals, overall studies, have had surgery and chemo. The best therapies are mostly immunotherapy, although there's some caveats. And so our clinical trial approach for patients with surgical disease right now is to combine those strategies in a fairly intensive approach where we give it pre-therapy, neoadjuvant, surgery, and then adjuvant for a year. And so even though I think operating up front is important, given the Mars 2 data, given the high recurrence rates, my bias is to put patients on the NEMO trial who are potential surgical candidates right now.
Thank you, Dr. Ripley.